Hi, everybody. My name is Eric Simpson. It's a real pleasure to be here at the first inaugural resident meeting for atopic dermatitis and the IEC. Thank you so much, Dr. Bissonnette and other organizers for inviting me. And it's a real pleasure to be talking about the current and new and upcoming systemic agents for atopic dermatitis. So I do have some disclosures. I'm a consultant investigator for many of the companies who are making these new therapies for more moderate to severe atopic dermatitis. I don't do any promotional speaking. So here's the agenda. So I'm going to give some unsolicited advice, I guess, from a career in atopic dermatitis investigation. Just some tips and tricks, I think, for those of you who are starting a career. So it's very encouraging to me to have all of you interested in atopic dermatitis and interested in science, or you probably wouldn't be here today. We'll identify patients who need systemic therapy. So that's kind of step one before you start deciding which therapy to use with your patient. We'll talk about traditional systemics as well as dupilumab and an update of that. And we'll talk about emerging biologics as well as emerging oral JAK inhibitors. Okay, so here's my advice to you. I think it's an amazing field to study, so I highly encourage you to get involved in atopic dermatitis research and patient care because the burden is just so great. It's really gratifying every day to see patients who started with such a severe burden on their entire life, either if you're a child or an adult, and the burden on social life or school, or confidence, etc. And to see these patients turn around, it's just super gratifying to treat the patients. It's a very prevalent disease, so it's a very important disease because of that global burden. The prevalence, the comorbidities, the heterogeneity, the mysteries makes it, there's so many research questions and things we do not know about the disease. So we really need your help, and we want to encourage you to continue to help us answer the questions for our patients with this disease. I recommend getting additional research training if you're going to start a career in academics at all. I don't care what you do, even if you're not primarily a researcher. Masters of Clinical Research, MPH, Masters of Clinical Epidemiology. I think all those are extremely helpful to give you the confidence to design the right trial or the right study, given the question that you may be posing. Try to publish a couple studies in your area of interest to get you started, to get your name out there. And then things just start snowballing after that over time. It takes years, but it's a really fun road to travel. And you need influential mentors. So people who are going to look out for you, who you're going to have some chemistry with, and who will help you understand the gaps in the field to pose the most important questions, and to help you network and make other new robust collaborations. A few more words of wisdom. Always keep the patient at the center of your decision making. So always just go back when you're thinking, working with pharma, doing talks, whatever. Is this, am I doing what's best for the patient? And then when you're thinking about studies, ask the so what. Like, is this going to move the field forward, or is this just like kind of an interesting thing to you that really is not going to help anybody? So think about that so what question when you're posing your questions. And then remember, like, don't try to plan this huge behemoth of an RCT to answer like one of the toughest questions in atopic dermatitis. The baby steps, What About, and this is not a real book, Baby Steps is from What About Bob, one of my favorite movies. But remember that's okay. Those baby steps are okay. That's how science progresses. It builds upon these baby steps. And then just a couple pet peeves. Don't apply kind of one basic science study or even one epidemiological association to patient care. I mean, raise your bar in terms of applying evidence to patient care. And that takes a whole volume of literature to kind of make some of these important decisions in the clinic. And then always question people like me about, if I go up there and say, you need to do this, you need to pour clobetasol into this moisturizer, and that's the only way you can, always question really strong opinions, including my own. And that'll make you a better, more critical thinker, better scientist, and better physician. Okay, off my soapbox. How do we identify patients who need systemic therapy? This drove me crazy. I kept getting asked by pharma, how do you define mild to moderate? How do you define moderate to severe? And then when I started asking, why are you asking me that? Well, because they wanted to know, how do you define someone who needs systemic therapy? And so that's the more important question in my book. And so we went to the IEC and we got all of the KOLs together to try to come up with an international consensus. And it really was pretty simple at the end of it. So everyone from different countries came up with the exact same idea. And actually the psoriasis, the IPC and the MPF came up with very similar guidelines just very recently. And we did this back in 2017. And we concluded that it's not an easy score, it's not an itch score, it's not a body surface area. It's really if aggressive topical therapy, meaning good topical steroids, along with non-steroidal, proactive, reactive treatments, being very good about it. If that's not sufficient to reduce the impact on the quality of life of your patient, that's a systemic candidate. It was that simple. Now we had some caveats, make sure that there was adequate education delivered, so the patient's not is kind of following the treatment plan, and especially for topical therapy. You've addressed infection. There's not a chronic infection that could be driving it. There is still that large impact on quality of life. It gives you a chance to reconsider the diagnosis, make sure it's not CTCL or atopic allergic contact dermatitis, and then consider phototherapy before systemics, and then you're ready to go. And so don't forget when you're assessing the burden on a patient, and there's additional burdens that might come into play that you could overlook when you're thinking about going to systemic therapy. Remember, dyspigmentation, hyperpigmentation adds additional burden, especially in our patients of color, hand involvement, face involvement, skin infections. These all add to the burden. And in my book, mean that they should probably be treated with systemics if they've failed topical therapy. And then also remember, and you'll just see this as you go along in your career, there's these additional burdens that aren't studied or aren't identified that really play an important role. So physicians saying, just stop scratching. It's the itch scratch cycle. If you stop scratching, your disease is going to go away. At least that's what it implies. And so patients come with guilt, actually, that they're causing their own disease. The burden and stress on the patient, but also on the family and the parents. Chasing the allergen is one of the biggest kind of mental challenges for patients, and having to come to grips with, I'm not going to cure it. It's coming from a type 2 inflammatory burden within me. And so that's very hard for patients to hear and to understand. Physicians provide two difficult and complicated topical regimens that are like not feasible. So yeah, you can get people clear in 1 week or 2 weeks with wet wraps, but what happens after that? So you can't sustain that type of topical therapy for your lifetime. Embarrassment, stigma, all the false IgE and unfortunately IgG testing, internet misinformation, etc. So this is just a huge burden on patients, and I highly encourage you to care for these patients and care for them aggressively to get their quality of life back. And then don't underestimate the power of topical steroids to either play an important role in long-term management, but also if they're overused. So they're often underused, but if they're overused, that's a problem too. And that's a reason to go to systemic therapy. If the only way they stay clear is with daily topical steroids, medium potency or higher, that's a problem. That's not sustainable over the long haul. You're going to get perioral derm on the face, you're going to get atrophy in the flexures, and you're going to get steroid withdrawal in the face, especially moderate to severe eczema. If they've been using triamcinolone on the face for any time over, probably 3 months, they're going to get this steroid withdrawal, which is really tough to treat and under-recognized in my book. Okay, so I want you to be consultant dermatologists, not referring dermatologists, okay? Traditional systemics, these are the what's used in terms of guidelines. We have a lot of data on each of these. They all show placebo-controlled data to a certain degree, and we use them all, with some being more common than others. I think this is an easier way to classify it, in terms of kind of patient risk and effects. You have your biologics, your traditional immunosuppressants, JAK inhibitors, and phototherapy. And we use the patient context to decide what's best for them in communication with them. So comorbidities, you have to think about the disease severity. Do they need to get better tomorrow? Or are you thinking about putting them in the hospital? Or do you have some time? Do you have 3 months to maybe, let's say, start methotrexate and wait for the results? Have they already failed methotrexate? What are the previous therapies they've been on? Did they have side effects from cyclosporin? Did they have side effects from dupilumab? And then risk aversion. If they want the safest thing and they never want to worry about risk, then that's another consideration that you would use when you're talking to patients about these different therapies in this shared decision-making type process, where you talk about the options, you talk about what goals they have, and what would be best for them from your medical perspective, trying to provide some choice if possible. So let's talk about when do we use these more traditional therapies. Cyclosporin, I still use it quite a bit when you want rapid relief, you need to get off. So oral steroids is a common exposure. When you come off them, it flares, it gets worse. And so many of these patients are in this roller coaster escalation problem of their disease with oral steroids. And I find that cyclosporin is extremely effective to try to get them off of this roller coaster, reduce the inflammation, and cyclosporin is very good at that quickly. If the patient fails dupilumab or it's not covered, you have a pediatric patient where maybe dupilumab is not approved yet, under 6, cyclosporin is very well tolerated. Start at the higher dose and then taper down over the course of several months to find the lowest dose possible. But then there's a year, you got to think about plan B, because you can only be on cyclosporin for a year. When not to use, older adults who have tendency to hypertension, have had cancer, or serious infection, of course, would not be good. You have to think about drug interactions. And then COVID pandemic, I was worried about at the beginning, but I'm not that worried about it now. And I've been prescribing it during the pandemic. The data show that it's not that big of a problem in patients coming into the hospital with COVID on cyclosporin. And in fact, some data show that the higher dose of cyclosporin, you actually do better, maybe because of that anti-inflammatory response. Methotrexate, if you have a more moderate patient, you have some time to wait, or you're trying to transition from cyclosporin to something safer long-term, dupilumab's not covered, you can use it as an add-on. No data out there, but I use that off-label. Not sure, if you're not sure about the diagnosis, these older adults with dermatitis, is that atopic? Is it something else? Methotrexate is kind of a nice way to go. This chronic eczematous eruption of the elderly, and you can use it in children 0.2 to 0.6 milligrams per kilogram weekly. When not to use, heavy drinkers, liver comorbidities, women of childbearing potential without contraception, and then it's probably safe during the COVID pandemic as well. But vaccine responses may be slightly blunted, so we stop it for a couple weeks after COVID vaccine. Dupilumab, really, there's no contraindications. Any patient who needs systemic therapy, I think, is a candidate, unless they have an allergy to the drug, of course. And you need a long-term approach, which is pretty much 100% of the time in an adult patient, and maybe not always in pediatrics. Underinsured, I put in brackets of when not to use, because I want you to advocate for your patient. And so don't let that be a barrier. There's a lot of ways to potentially get them drugged. Needle phobic patients, and then COVID-19, it seems to be perfectly fine. I kind of go through this discussion. These are the pros and cons of cyclosporin, pros and cons of methotrexate, pros and cons of dupilumab. Most patients pick dupilumab because of safety and no lab monitoring. But I have some patients who just last week in the multidisciplinary clinic, he felt cyclosporin was best for him. So really, you're sometimes surprised actually which one they pick. And so try to be, and if it's safe for them and and they're all appropriate, give them the options and let them choose. And I think that there's a lot more buy-in in this team approach. Dupilumab update. This is just an example. A patient on multiple immunosuppressants, kept getting EH, kept getting staph infections. This is the kind of patient you don't worry at all about putting on dupilumab. It's not immunosuppressive. It reduces skin infections. And this is him. This is at 1.5 years. He's like 4 years now on drug and doing remarkably well. So it's been a real lifesaver for many of my patients in our clinic. Some updates. The long-term safety look excellent over at least 3 years and beyond. It's approved down to 6 years of age. You have reduced skin infections, reduced staph colonization. If you measure it by quantitative culture or PCR, quantitative PCR of staph, it amazingly reduces colonization. We've been doing some of that work through the Atopic Dermatitis Research Network from the NIH. Elderly AD appears to be safe and effective, so that's extremely helpful for older patients who have dermatitis. Even with non-responders early on, they can capture responses later. There's case reports and off-label use in patients with other systemic problems and other infections. It appears to be safe, even in Hep B and C, and really no laboratory monitoring required. And the concern is facial dermatitis. So my point to you regarding facial dermatitis is don't panic. There's a lot of causes of facial dermatitis in a patient on dupilumab. It's not always dupilumab. It's a whole differential of refractory AD, allergic contact dermatitis, steroid withdrawal, cyclosporin rebound. I've seen it all on facial derm. So just apply a differential. If you get facial derm on dupilumab, it's not caused by dupilumab. Just like in this case report, if you get rosacea on dupilumab, it's not caused by the dupilumab in my book. That's what they ascribe it to in this paper. But this patient was also on topical steroids and oral steroids. And so I'm not necessarily a believer that dupilumab causes rosacea. There's a lot of confounding factors. So be critical when you read the literature, be critical when you listen to people like me, including me. This was cyclosporin withdrawal. There she also had contact dermatitis to methacrylates from her nails. Emerging biologics. So welcome to the future. So we have dupilumab, that's IL-4, IL-13 blockade. What about IL-13 alone? Well, IL-13 appears to be very important, probably more important than IL-4. However, the efficacy of tralokinumab, which is IL-13 cytokine blockade, seems about like maybe half of dupilumab in terms of effect size. It's effective, it's better than placebo, it's safe. There may be fewer cases of conjunctivitis, but there still is a conjunctivitis signal. It's slower acting, seems to be longer acting after you stop the drug potentially. And that's going to be approved soon it's at the FDA right now. So that'll be an option for you. It'll be up to you as a clinician to decide, well, where does that fit in my algorithm? Would patients choose Tralo over dupilumab? And so you'll have to work that out on your own. There's a lot of other biologics that you'll have to continue to work out. Where does this fit in my armamentarium? How am I going to describe this to my patients? Lebrikizumab, another anti-IL-13. IL-31 is a heavy itch cytokine that is an important itch cytokine that is being studied. Another IL-13 receptor blocker that would not affect IL-4 signaling. This anti-OX40 is a really interesting mechanism of action. And then there's been failed biologics. So there's a lot of activity right now. And a lot of these keratinocyte cytokines are failing in the clinic in phase 2 studies, unfortunately, but we're just happy that there's a lot of activity so we can learn about the disease and find new options. I'm going to skip the OX40 slide just for time, but just know it's a really interesting co-stimulatory pathway, and you can block either the ligand or the receptor. And we're getting positive phase 2 results that were presented just last week at the EADV. So that's going to be an exciting new MOA. Last, we'll finish with oral JAK inhibitors. There's a lot of them in development, even for pups, highly effective. All my patients say their dogs stop scratching immediately, and we're starting to see that in our patients as well, because JAK signaling is important, not just for inflammation and for cytokine and for what cytokines used to signal to the nucleus, but they're also important for itch transmission within neurons. So you can have both a direct and indirect effect on itch reduction, which is a real big feature of them. So why would we need JAK inhibitors? It's because we still want more efficacy. Dupilumab clears 38% of patients or so, would almost clear at week 16. I want 100%. And so this is a potential way to improve that efficacy. We want a drug with no conjunctivitis. An oral route of administration would be helpful. Some dose flexibility would be helpful. So the question is going to remain, can JAKs fill this role? And so how could they improve on efficacy? Well, we know the inflammatory infiltrate is much more heterogeneous than just IL-4 and 13. And JAKs do block a few more cytokines than just IL-4 and IL-13. They block a host, if you block JAK1, a host of important cytokines in atopic dermatitis infiltrate. So that's how they can work that way. But so some general comments, they all improve itch quickly. It really depends on molecule and dose. And so think about that. Molecule and dose is going to tell you what the efficacy is and what the safety would be. All three are appropriate as first-line treatment, but the FDA may not allow that, but that's just my opinion if you pick the right patient. And then remember, you're going to have to learn these. I don't have time to go over to, all 8 phase 3 trials of every single JAK inhibitor. Remember, you're going to have to learn, what do I need to look for? What are the rates I need to look for so I can help counsel my patients? You have to look for tolerability, headache, nausea, acne, herpes simplex, herpes zoster. These are all elevated over placebo. Serious infections, not that big of a deal, actually, so far in atopic dermatitis. Venous thrombosis, rare events, but they're happening in higher rates over placebo for Abro and for UPA. The lower dose of Berry, I don't think it's occurred yet in a study, but those are all potential risks of that class. Major MACE events are a potential risk. Malignancy is a potential risk. So pick your patient correctly, have that discussion with your patient. But if you need rapid results and you want some dosing flexibility and you want an oral therapy and they failed Dupy, for example, this would be a great use of that drug. So if you just look at how well this works in the last few seconds here, baricitinib in the blue bar, about 10 to 11%. It's been as high as 24% clear, almost clear, but not quite as effective as dupilumab. Abrocitinib, and these are just caveats, right? There's no head-to-heads at this point. But now I do have head-to-heads of abrocitinib, which is higher, clear, almost clear at the higher dose than the Berry, it looks like from this perspective, 44 or 38% clear, almost clear at the higher dose. And then upadacitinib is like 62, 52% in that range, clear, almost clear. So there's a head-to-head of Abro versus Dupy. Abro at the higher dose beat Dupy. In terms, just numerically, no statistical significance was performed. The studies, that calculation wasn't performed, but it seems to be about the same as the lower dose of Abro. And then there's a head-to-head, this was just published last week, that UPA was better than Dupy in multiple time points, including at week 16 at these high thresholds. So this is EASI-90 on your left. UPA is higher, 60% EASI-90. That's incredible. Better than dupilumab. Better itch control with high dose of UPA. We don't know about lower dose UPA. So, but this is the black box warning you'll have to understand. Serious infections, mortality, MACE events, thrombosis. This is the upadacitinib. They're all going to look like this. You need to know the numbers and know how to cancel your patients. So in summary, unsolicited advice, we need you, thank you for being here to move the field forward. How to identify systemic therapy, people who need it, topical failures. Traditional systemics still work, be comfortable using them. Dupilumab update, don't stop prematurely just because of facial dermatitis or conjunctivitis for that matter. Emerging biologics, nice alternatives to Dupy or for failures of Dupy. And oral JAK inhibitors are potent, but you need to choose patients wisely. Thank you so much for your attention.